Thanks so much. The updated findings of QUILT, of the QUILT study, actually looked at CIS patients with and without papillary disease, as well as papillary disease only in that BCG unresponsive space. And with it, the long-term follow-up for both CIS groups as well as for the papillary groups, there were some significant findings. So within the CIS group, with a median follow-up time of more than 2.5 years, you saw that the complete response rate maintained itself at around 71%. But then kind of the key findings were three different areas, I think, which were points that were raised within the abstract. First is that durability of the response, the question you basically focused on looking at how did patients do in the long term. And what was found was in that cohort of patients that was approved by the FDA, looking at the patients with CIS disease, with or without papillary disease, that were BCG unresponsive, we saw actually that the duration response was significant. So more than 50%, 51% of patients actually had a complete response for more than 45 months. So that tail of the curve actually seems to be a real one in that once you get a complete response, yes, there'll be some patients who will have disease that recur, but importantly, a significant number of patients over a significant period of time actually will maintain that complete response state. And in fact, there are patients actually with more than 53 months of a complete response, no evidence of disease situation following actually treatment with the combination of NAI or N-803 and BCG. Second key finding is the safety of this regimen. And what I mean by that in terms of cancer-specific or disease-specific survival, so that basically 99% of patients greater than 3 years of actually a disease-specific survival. So that the fact that with the longer follow-up, that disease-specific survival maintained a significant safety shows the safety of the regimen. The third key finding was the focus on actually cystectomy-free survival. So avoiding that need for a procedure. And over time, obviously, some of these patients will require a cystectomy. But at 12 months, 24 months, 36 months, that number remains actually quite high. And at 36 months or 3-year follow-up and 3-year cystectomy-free survival rate was in fact 84%. So those were the key findings for the CIS group. Similar findings were found in the cohort B or the papillary group, and that included a cystectomy-free rate of actually 82% beyond 3 years, and that disease-free state, so without evidence of disease, actually was significantly maintained for a long period of time, more than 52% beyond 2 and 3 years. So overall, the long-term kind of results of these, both in the CIS cohort and the papillary cohort, showed a durability of response that was actually impressive. So Dan, I presented some of this data early on with QUILT at actually ASCO GU, and now these are the long-term results. A lot of exciting findings when you look at the different treatment options. We've got N-803 or NAI, trade name Activa, now currently available. We have Adstiladrin available. We have non-intravesical options, pembrolizumab available. With that, this data actually now adds to our knowledge regarding kind of long-term durability of response. As we treat our patients with BCG unresponsive disease, kind of tell me what you think about options that are out there, and as you discuss them with the patients.
Yeah, I mean, I think it's interesting that endpoint too of cystectomy-free survival, different obviously than the response rate. So even when people recurred, they were still avoiding cystectomy, and that's what these patients want. And I think that's what we're seeing with these lot of single-arm trials, no comparative head-to-head data. Well, we now have a lot of different options that if one treatment fails a patient, we've got a bunch of other options up our sleeve to still kick cystectomy down the road and provide good quality of life for these patients. I think N-803 is nice because it does pair with BCG, which is a very different way of approaching BCG unresponsive disease compared to some of the other treatments that are out there. So How do we sequence these? No idea. No idea.
Yeah.
But I think it's going to take some nuanced approach. It's going to take better work in the biomarker space to understand which patient is going to be best for which of these treatments. And right now, it really is. I think a lot of it comes down to what the patient has to go through to get the treatments. And I know with my patients, I talk to them about what the administration process is for all of these different drugs. And ultimately, I tell them the data and tell them what they want. And often, what they want is the thing that's going to be the least onerous to them and the easiest to get.
So as always, pearls of wisdom from the statements whenever I talk with you. I think when you talk with the patients, you talk about, okay, what's FDA approved, what's not, in all honesty, what can be placed into the bladder, what's not placed in the bladder. You have all these options in addition to bladder removal, and there are clearly some data actually presented at the AUA in 2025, the cysto data, the
Yeah.
CISTO data led by Dr. Gore and Dr. Smith really showed actually the positive impact of cystectomy in patients actually with non-muscle invasive disease, uh, functional well-being, social well-being, overall quality of life questionnaires. So we always have to keep that in mind. But the other key point that I wanted to kind of reemphasize that you made is the fact that sequencing will happen. I think that the majority of patients will see different medications as we attempt to try to control and or eradicate the disease. And that there can be, for certain patients, a significant long-term durability of response. And the question is, who gets what when? And so the treatment schedule, I think, will be very important. Tolerability will be important. And I think ultimately cost should be very important as well.
Yeah, I love that you mentioned the cysto trial. We're going to get a lot of data out of there that is super important for patients. I know they're looking at financial toxicity as well. And in some cases, for some patients, more aggressive surgical treatment is going to make sense. And so I think it's really important to know, yes, we're preserving bladders, but what does that really look like from a quality of life standpoint? And that includes the financial side of that and how it's impacting their quality of life.
Yeah, so the combination of the biomarker data that you were talking about, that can help identify those patients at higher risk that should ultimately proceed to timely cystectomy. That's a term I'll attribute to Mike Cookson, who really came up with that. Timely cystectomy in these patients with non-muscle invasive disease. You add that, and then you consider all the other things, quality of life, patient-reported outcomes, financial toxicity, those things, honestly, that as physicians, we've tended to I don't want to say underestimate, but I'd say underappreciate
Hmm.
and not really know the true manifestations of the impact of different treatments really make a difference. And so having the biomarkers out there that I'm sure we'll gain more information of, I think that'll give us an idea of cystectomy, yes or no, we should really push for. And then if we don't push for cystectomy and we aren't able to, then the idea then will be, okay, how do we balance the pros and cons of these different intravesical therapies? And there are a lot of trials going on as well.
Yeah, absolutely. I wanted to ask you, so high grade TA, BCG unresponsive versus your CIS patient, how do you view them and what do you tell them about the different treatment options? Do you view the treatments any differently?
Yeah, that's a great question. If you look at the data from the Adstiladrin kind of portfolio of trials, if you look at the data with N-803 or NAI, you see that actually these are beneficial in the papillary groups. Perhaps there may be a higher recurrence rate, et cetera. It's a little bit, I think, a different disease process, but ultimately, I think these medications will show benefit, and a significant number will be able to avoid cystectomy, avoid progression in terms of death associated with papillary disease. So I see them as different disease entities, but also can be effectively treated with these regimens.
Yeah, I struggle with that a lot because there's a surgical component to that as well. And the effectiveness of the TRBT, much of which you've talked and written about, really matters in those papillary tumors. I think maybe not as much in the CIS because often we can't see it to resect it.
Yeah, and actually a really good point regarding the importance of that TRBT, because right now these studies are being done basically in an adjuvant type setting,
Yep.
assuming that removed all of the tumors. I think exciting studies on the block and have actually already been done looking at actually ablative therapies with the intravesical treatments so that we can actually kind of hopefully level the playing field and treat the entire bladder. Even lesions that may be missed, quote unquote, by TURBT, being able to successfully treat these patients, I think adds yet another different component of how do I decide between these different treatments?
Absolutely.